Hello? Doc? I don't know why I'm not able to see anything.
Okay, you can hear me?
Yes, I can hear everybody. Hi.
You can see me now?
I can see you, but I can't see Doc Fundile.
Okay, well then I can see. Okay, good.
Are you able to see him?
Let me see. Gallery. Yes, I can.
Oh.
Get this up. Okay.
Are you able to see all the other participants?
Yes.
Oh.
So we're boiling the tea, steeping the tea in the milk. How many people out there show up every day to drink shots?
Good evening to all our various viewers on Dr. Nyati's, Dr. Fundi's platform via Facebook, via Twitter, via YouTube, and on his channel, on the Dr. Fundi channel. My name is Pelokazi Ntombi yakwaNyathi, iBhelekazi. Ndizalwa ngamabhele, ndathwalwa sisizalo songwanya. Ndithela uhlaba ke ibhelembe ndathi nam mandisabele kuba kaloku sijongene nemfazwe yokuphela kwenzala kamama uAfrika. Kaloku nam ndingunozala yaye iyasika inimba xa kunje. Uthi ke ufikile unqunqayo ekuthiwa nguCholcholo ndathi esi sililo xa sisitsho isizalo sikamama uAfrika sikhala. Ndathi hayi nam mandisabele kuba kaloku iyasika inimba xa kunje. Banintsi bathi igazi liyajiya kunamanzi. Kaloku thina sakhuliswa ngobuntu yaye siyavakalelwa xa kunje. Xa isizwe simnyama sithulula iinyembezi. Kuthi xhoko kweyam intliziyo kuba kaloku umzalikazi Afrika ujonga abantwana bakhe bephelela phantsi komhlaba. Mbombo zone zomhlaba iselwa lihlanza lihlanzile. Nina ke zingqondi khanikhe nihlanganise amathambo engqondo nize nesisombululo sanele thina ile ndyikitya yokufa. Sanele thina zinyembezi neentlungu. Khawuthatha intambo ke bhele ndisaya kubhodla camakho. Bhele, Dlambulu, Langa, Mbutho. Intambo ndizinikela kuwe. Ndithi ke khawuthethe ke nababukeli uthethe nabamameli.
It's different, this one. It's like a webinar thing. That's what they say. I don't see that option. Okay, so where's my volume? Okay. I can't hear now. Why?
Meeting.
Huh?
Meeting.
But he's talking, I can't hear you.
Meeting. No, call me meeting. Yes, because joy volume. Full order.
We can't hear Fundile speaking.
Back at the pizza parlor, as the bins outside were picking up, customers were getting nervous. Panic. They walked out the front door and watched the empty sidewalk, and they almost immediately came flying back in. Just because they saw trash flying in here. And then took a second walk and realized, oh, it's actually a tornado. And he started hey, we should be running faster. That's not the safest place to get beans back. Always nothing but cement. So the safest place for us to use in that cement hallway.
Doc, are you on?
Me,
Can everybody hear Fundile? Because I cannot hear him.
I can't hear him.
Okay, all right.
Good morning, Amanda. Can you hear me?
Yes, I can hear you, Mom. Good morning.
Or good afternoon, I guess.
I know.
I can't hear Fundile.
Is he talking? Has he started?
Yeah, Pelogazi, try to get hold of Fundile. We can't hear him at all.
Monway, can you hear me?
Yes, now I can. Now I can hear you. Yes, I can hear you.
Can
now.
everybody hear me?
Try to get hold of Fundile. We can't hear him at all.
Okay.
Now I can hear you. Perfect. Thank you.
Can you hear me now?
Yeah, we can hear you now.
All right. Apologies. Technology has got a way of just making things to go very wrong. All right. Can I ask everybody to just put their mics on mute for now? All right. All right. Can I ask everybody to just put their mics on? Can you hear me? Okay. All right. Apologies once again. Welcome to all of you, our panelists from across the Atlantic Ocean, and also panelists who are joining from this side of the Atlantic Ocean. I've got a number of panelists here: Prof. Washington, Prof. Amanda, Mona Davis. Those panelists are from America. And then on this side, we've got Dr. Monwabisi Kancho. We've got the Honorable Minister Senzo Mkhunu, who is the Minister of Public Service and Administration here in South Africa. So those are the members of the panel. We are still waiting for Damon, who will join us a little later. However, the program will proceed and he will just join us when it is the right time. We have a number of people who have joined in as participants to this webinar. And with time, I'm actually going to promote many of them so that we can actually see them on the screen here. All right, now I just want to mention why we have this topic today. I am a person who is always commenting on radio and on TV about the COVID-19 pandemic in South Africa and also across the world. So I keep track of what is happening in many parts of the world. So a few weeks ago, I was intrigued by information that was coming out of the US, information that was pointing that there's a disproportionate impact of COVID-19 amongst people of color in the United States of America. The information that came out from the CDC, Center for Disease Control, showed that minorities in the USA, that is African Americans and Latinos, were overrepresented amongst people who had COVID-19 and who were actually succumbing of the disease. Also, it showed that there was a risk-based dependency in terms of who gets this infection and who actually dies of this infection. It showed that African Americans were 3.57 times more likely to get infected with COVID-19 as compared to their white counterparts. It showed that Latinos were 1.88 times more likely to have COVID-19 as compared to their white counterparts. Looking at the cities like Chicago and Illinois, where the Black population, the African American population is about 30%. However, when one looked at the deaths in those cities, the African American population, they had about 65, or they made up 65% of the deaths, more than double their proportion in those cities. If you look at a city like Detroit, Michigan, where African Americans make up 14% of the population, they actually made up 39% of the deaths. If one looks at New York City, African Americans, they make up 22% of the population, yet they actually made 28% of the fatalities. So in all of these big cities, also in Boston, African Americans, they make up 25% of the population. However, they made up 40% of people who were COVID infected. And to round it up, looking at the preliminary deaths rate, they reported that Latino people are likely to die 22 out of 100,000 population. African Americans, 20 per 100,000 population. White people, 10 per 100,000 population. And Asians, 8 per 100,000 population. So I shared that information to just give a sense of the fact that as much as the people of color are minorities, in America, but when it comes to this pandemic, they actually were negatively affected, and it can't be a coincidence. It must point to something that is wrong in the socio-economic circumstances of those minorities. Now, so the reason why I've invited the various people from the US is for them to share with us what could be the drivers of what we are seeing. Are there any historical reasons why we are seeing that picture? Those who understand the socio-economic dynamics, are there any socio-economic issues that are worth looking at? Now, coming back to the South African situation, in South Africa, we had our first case of COVID-19 on the 5th of March. That's just over 3.5 months ago. Since then, our numbers in terms of confirmed cases, they've gone up to about 87,000. That is the total cases. We are now at a point where our numbers are actually the same with China in terms of the caseload. We have already surpassed many other countries, but the good news though is that 55% of these cases in South Africa have already fully recovered. We, however, have lost about 1,831 people, which is 2.1% of the number of people who have been infected. Males make up the majority of people who have succumbed to COVID-19 in South Africa at 52%. And 4 provinces in South Africa, we don't have states, we are just one country with 9 provinces. So 4 provinces, 3 of them by the coast, which is the Western Cape, the Eastern Cape, and KwaZulu-Natal, and 1 inland province, which is Gauteng. They make up 95.8% of the caseload in this country. So the rest of the 5 provinces, they make up just over 4% of the caseload in the country. Now, something that is quite important from a race point of view, there was some data that was shared by the National Institute of Communicable Diseases here in South Africa, looking at a period from the 5th of March to the 31st of May, which is just about a 3-month period. What they found was that amongst the people who were admitted to hospitals, both in the public sector and the private sector, there were 4,718 admissions during that period. Now, there were some key revelations when one looked at the data there. One thing that came out was that Black Africans, they made up 63.7% of people who were admitted as a result of COVID-19. What we call coloreds or black coloreds in South Africa, they made up 19.1% of the people who were admitted to hospitals across the country. People who were whites, they made up 11.6% of the total caseload. And people whom we call Black Indians or Indians, they made up 5.6%. When you add the Black Africans, the coloreds, and the Indians, which is the blacks according to South Africa, we include all of them amongst blacks, they make up 88% of the people who've been admitted. Now, and this is a period before this pandemic went to the provinces where you've got a majority of Black Africans. Now, one of those provinces, which is the Eastern Cape, has had an exponential rise over the past month since the beginning of June. And so what we see here is that the blacks are likely to constitute more than 90% of the load in the next few months, which is almost the similar situation that we are seeing where there's a disproportionate percentage of blacks being affected by COVID-19, not only in terms of infections, but also in terms of deaths. And when one looks at the African continent as a whole, South Africa has the highest load of COVID-19 infections. We are #1 in terms of the number of infections, but we are #2 in terms of the number of deaths. So we are followed by Egypt, and then Nigeria, Ghana, and Algeria. So those are the top 5 countries in the continent of Africa amongst 54 countries that make up this continent of Africa. And South Africa has got the most number of people with COVID-19. So with that background, I was trying to just give a sense to say, in America, they are now, getting out of the peak. Yes, we still see a lot of infections there, but the numbers are not rising as rapidly as they were about a month ago. All right, there's a lot of theories, obviously, around the issue of the weather and what it does to the spread of the pandemic. So we will look and see what happens there in the US. But we invited our guests from across the Atlantic so that they can share some notes with us around, the drivers and whatever else they think is relevant, because we are still getting into our peak here in South Africa. So with those words, I want to hand over to our program director, Pelogas.
Thank you, Dr. Nyati. With that, I guess everyone now gets to understand why there was a need for such a discussion or such a conversation, and also why it was necessary to have our friends from across the Atlantic so that they can also give us a bit of information about their experience. They're seeing that they are ahead of us in terms of the experience. So with that, I would like to introduce our next panelist. Amanda, you back? Okay. All right, I would like to welcome our next panelist, Professor Amanda Otter. Fortunately, this lady has got experience from both sides of the Atlantic, having been born and raised in Port Elizabeth, South Africa, but studied in Temple University, Philadelphia. She also works there currently. She stays there currently, but she's also got her tabs on what is happening in the continent of Africa. So over to you, Professor Amanda Otter. And if you can just maybe please tell us more about yourself so that people can understand why it was necessary to have somebody like you in this panel. Thank you.
Can you hear me? Can you hear me now?
Yes.
Okay. So good afternoon, everyone. My name is Amanda Otter. I was born and raised in South Africa, Port Elizabeth in the Eastern Cape. So I currently reside in New Jersey, and I work for Wilmington University as a professor and a satellite campus manager. So I just want to, Dr. Fundile, thank you for the privilege and this invitation, because this is a very important, topic. So, but I'm just going to give just a brief background about, what the situation in the United States, the healthcare situation. So just that actually makes the African Americans to be affected. So President Obama in 2010, as we all know, he presented the Affordable Care Act, which is commonly known as the Obamacare. So, and the Obamacare, literally the whole intention was to cover, uninsured Americans and also help the ones that have the gap insurance so that they will be covered. So before the Affordable Care Act was put in place, there were 46.5 uninsured Americans. So when the Affordable Care Act was implemented, it went down from, the uninsured Americans went down from 46.6 millions to 27.7, uninsured Americans. So, and this Care Act was actually accommodated many African Americans who, were the ones that were mainly affected. But it had all the stipulations and people were allowed to go to what was called the marketplace to shop for insurance. And it also covered, it decreased the coverage for the people that were under Medicaid too. So, but, with politics that always come in place, and we had a new president, the number went up in 2017, from 26.7 million to 27.9 million by 2018. So, and all of this, all this, instability in healthcare has always affected African Americans. And African Americans, majority of them are already living in a greater burden of diseases than their white counterpart. So they find themselves, like in a heavier risk. So that's why when the COVID came in, the COVID-19 came in, they were more affected by the COVID-19 more than their white counterparts, which Dr. Fundile had stated. So, and the inequalities within the US healthcare system also doesn't help because it impacts the people of color disproportionately, and it leads to unequal access of services such as, the testing, because, in the poor neighborhoods, which is where dominantly the African Americans are, they don't have access to testing, and also the healthcare, for them to be tested for the COVID, which is the literally the most part that help you to find out whether you are affected or you are not affected. And also the heavy segregation in the African Americans, like the neighborhoods that are mostly Black, tend to be medically underserved. And that's literally a norm in the United States. And there's so many other issues that the African Americans face in this country, in terms of for them not having transportation to the clinics, to the testing centers. So it literally affects them heavily than their white counterparts. And just for me, in my research, I've saw what the NAACP, which is the National Association for Advancement of People of Colored People, which always ensures that the society lives, have individuals that have equal rights without discrimination. So they've, been advocating for African Americans to have just effective health infrastructures, and just for them to have, some prioritization in terms of like testing. So it's really a big problem right here in the United States. And just from me now flipping onto the South African, side, where, so in the United States, as we all know, that African Americans are a minority, but then on the flip side, in South Africa, Black South Africans are the majority, but they are just as heavily affected because of the poor, infrastructures and the resources that they don't have, that are not provided for them to be educated, which is the number one issue, to be educated about the COVID. Because what happened was that, as Doc has said, that, how when South Africa came to, when COVID, was first in South Africa, people in South Africa, they just, were listening to, the news on CNN about the COVID in the United States, China, and the Italian, and in Italy too. But they didn't know anything about it. So my whole issue was that, has anybody ever taken just, the time to educate people about what is this COVID and how do people, get the COVID? We understand that you have to wear a mask, you have to, do the social distancing, but just, I just feel that, there should be some, provisions for people to be mainly educated. So that's my intake about just, how the COVID has, impacted the United States and, in South Africa. So that's my intake about just, how the COVID has, impacted.
Well, thank you so much, Prof. Otta, and we really appreciate your input because we believe that you there and you experiencing what's happening on that side. However, some of the things that you've experienced will help us on this side of the Atlantic. So it's very important for us to understand that these two parts of the world are actually connected. Because
Yes.
remember how this virus, to start with, got moved from one area to another is through all the travels that are happening intercontinentally. So it's very important for us to, to understand what your experience is, so you can help us in also maybe strategizing on how we can help our people on this side, especially when you've got the experience of the South African context, so that we can use that to, to find a way of making sure that it doesn't impact on us as much as it is now, or it might in the future. So thank you so, so much. We really appreciate that. And so in the latter part of the program, you will have an opportunity to answer questions or maybe to give more information after the interaction with the various other panelists. So thank you so, so much.
You're
So
welcome.
now we're going to move to our next panelist, Dr. Mona Davis. Welcome, welcome to the motherland. And thank you so much for giving us your time so you could share with us what your experiences are around the inequalities, around quality healthcare access in the United States, and also to maybe just give us a few advices on how we can take what your experiences is from that to how we can also find ways of sort of reducing the impact on the people of color in this continent. Over to you, Dr. Davis. If you can tell us more about yourself before you start there.
Okay, good afternoon, everyone. I am so grateful to be able to share with you this afternoon. Thank you for the invitation. It's a wonderful opportunity for us to be able to discuss health disparities as we move forward. This has impacted us in a tremendous way that we've got to get a real handle on, whether it's education or understanding, and just some background on what we needed to talk about to bring this platform forward so that everyone does not have the same experience that we're having here in the United States. One of the things I wanted to talk about first was the difference between equality and equity. And so when we're looking at what equality means, and equality will bring an even slate for everyone. Everyone will get the same service. So if your tooth is hurting and you go in the dentist, we say, here we are, we're going to clean everybody's teeth. Well, if my tooth is impacted and I need a cavity filled, then you cleaning my teeth is not going to help me. So that's where the equity component comes in. So we're looking at how we increase the opportunities for health disparities in equity. The same situations that we were experiencing pre-pandemic are the same experiences that we are having post-pandemic. There are a lot of health disparities that cause you to be predestined to be susceptible to this pandemic. And so that will automatically increase the numbers of not only infection, but also the mortality rate that we're experiencing and having the highest numbers because our community was already adversely affected with healthcare issues. If those are not addressed in the onset, you can expect nothing but impact and disparity across the healthcare nation. So while it's impacting us more, it is because our healthcare is not as prevalent as it is for other races. How do you maintain something like that in a free world? That's what we're grappling with every single day. But I did want to talk about some things that we need to look at from the beginning when we were talking about numbers spiking and where the curve is and where the curve is not. We just received some information on Friday that our numbers in North Carolina had gone up to brand new cases of over 1,000 cases in one day. Across the state, we have begun the process more intensely to test, to track, and to trace. So while you have numbers that may reflect lower amounts, if people have not been tested, their numbers are not going to appear. Once you are tested, that gives you a more accurate understanding of where you stand in trying to battle this pandemic. So the first thing that you want to be actively engaged in is making sure that everyone has a test or has the ability to be tested. In our neighborhoods, a lot of when it first began, you needed a doctor. And so if you don't have health care, you would not have that option to be tested. And so the information is there. There may be quite a few people who are asymptomatic. So we're walking around, we don't have symptoms, but we're sharing what we have with other people because we don't have symptoms. We're not wearing masks, we're not social distancing, we're not doing the things, the cleanliness that's necessary to kind of keep this virus in some kind of corral because we don't exactly know how it's being transmitted, how long it lives, and what we can do to prevent it. So there are precautions that have been asked for us to put in place, but you have all kinds of, what shall I say, all kinds of entities who beg to differ. And if you get on the wrong train, then that's where it's going to impact us most. So the communication and the education of we have to be safe now in order to be productive in the end. Looking at what we were talking about earlier about social determinants for health, we're looking at what employment looks like. When you're talking about economic stability, that's the main objective that causes the disparities in healthcare. Employment, income, what your expenses are, what your debt rate is, if you've got medical bills, and what kind of supports you have in your life, in your family, in your community, your neighborhoods that you're living in, how's the housing? Do you have adequate transportation? Because if you are relying on public transportation, and we know that this is somewhat of a communicable virus, you're in the presence in order to get where you need to go, you have to use public safety. So there you are exposing yourself to something that we have already identified as can be in time. If you're spending over 15 minutes around a person that may have the virus, there's a possibility that you will contract it. So there are so many things that go into play with that, the education piece, making sure that you have education, that you understand exactly where we are and what your next step should be to protect your family and protect yourself. Food, that's another process. We understand if you've got destitute places that people are not being fed or they're not receiving healthy food, there you have another place. How do we go further in our quality of care or making sure that the cultural competency and the language barriers that we have, that people are not afraid to be tested. They're not afraid to let someone know that they're not feeling well. So there are so many things that feed into this that put us in a place of jeopardy that we've got to get education out. And it begins with testing, tracing, and tracking. If we can get that information out, I'm sure that we will be able to combat this in a way that becomes more productive and our numbers become more evenly dispersed across the nation. I'm sure that we will be able to combat this in a way that becomes more productive and our numbers become more evenly dispersed.
Well, thank you so much, Dr. Davis, and we really appreciate your inputs. And it's so interesting how we, as you guys are talking, we're realizing the similarities between the communities here and the communities on the other side.
Yes.
And so some of the lessons that you spoke about around issues of educating communities, I mean, just from that, to educate people about the virus, how it's transmitted, the things that people can do in order to protect themselves, I suppose are some of the lessons that we can take from your experience on the other side of the continent, of the Atlantic. And so one of the initiatives that we're quite aware of is that on this platform, Dr. Nyati and some of the doctors in one of the areas that are now starting to be hugely impacted by the virus, which is the Eastern Cape, a province on the coast. One of the initiatives that him and Dr. Ganjo and others have done is to ensure that that happens. So there's a number of initiatives that they're getting involved in ensuring that our communities understand what this is and what it will do to them should they not do the right thing. And it is also important what you mentioned about language, because if somebody doesn't understand what's being said, it's not said in their language, obviously they will not understand what's being said, and they will not understand the seriousness of what needs to happen. And so thank you so much for bringing that to our attention. And yes, it is something that we all have a responsibility in ensuring that it happens. And so towards the end of the program, we will allow people to ask you questions and for you to interact with the viewers at home. So now we'll move to our next the next speaker. And welcome and thank you so much, Professor Eric Washington, who is a historian and who is also somebody in academia who can tell us more about linking the challenges of the inequalities in healthcare access to the history of the African Americans in the continent of America. So over to you, Prof, and thank you so much and welcome.
Thank you, everybody. And I want to thank the conveners for inviting me. It's a great privilege to be on this panel this afternoon here in the States where I am in the state of Michigan. And good evening to you over on the continent. I teach African and the African diaspora here at Calvin University in Grand Rapids, Michigan. And I have the opportunity to travel to the continent most every year. So I'm conversing in both what's going on among African Americans as well as what is going on in different countries on the continent. So with that said, we have to put all of what's going on now with COVID-19 and the impact on African Americans within a larger historical narrative of African American history. What's going on now with COVID and African American history begins on the continent of African American history, beginning from communities in West and West Central Africa. So those who were captive and trekked some 1,000 miles to the coastlines, I mean, that right there was a harrowing health experience. And once we begin to look at what's going on, let's say on the barracoons that are dotting the landscape in places like Ghana and modern day Benin and Nigeria, up the coast to Senegal and Sierra Leone, where we see how captive Africans were treated in those barracoons. They were out exposed for days and weeks at a time before being put on slave ship. You had death right there in those barracoons. You had women who were pregnant, who were giving birth in those barracoons without any type of midwife there. So when we begin to talk about this history, we have to begin there. And then along on the ocean voyage from the west and west central coast of Africa on those slave ships were what I call floating death chambers. Of the 12.5 million captive Africans that were transported to the Western Hemisphere, approximately 2 million died en route on those slave ships. So once those ships landed in places like Barbados and other places in the Caribbean, and then in ports in North America, these folks weren't in the best of health, even though they were examined by would-be slave owners or slave brokers. So it begins there. And we talk about the whole institution of slavery, which we mark in North America, at least in British, what became the United States of America, the British North American colonies. We began that in 1619. So from 1619 until the very end of the institution in 1865, you have various experiences on farms and plantations, and definitely in the 17th and 18th centuries, especially the 18th century, where the transatlantic slave trade going to the British colonies was at its height. The health of enslaved people was nothing that slave owners had in mind, because they were chattel, movable property, and also expendable. It depended upon where you worked in terms of your life expectancy, but life expectancies were fairly short, and were shorter. Let's say if you were working, and where I'm from in Louisiana, on the sugarcane fields, the life expectancy was shorter because of the labor involved in harvesting sugar. So Louisiana, compared to the Caribbean, if you were an enslaved person and you were transported to a sugarcane growing area, your life expectancy was somewhere between 6 and 8 years. So that began to change in the United States once the transatlantic slave trade became suppressed, and that took effect January 1, 1808 in the United States. So, but even with that, there was this domestic slave trade in which enslaved people were transported from one region to another, sometimes by boat, other times on foot, going from places like Virginia in the upper South all the way down to my home state of Louisiana, which is on the Gulf Coast. That affected health. So basically what the argument here is that this 250-year period plus 250-year plus period of enslavement, what you saw was the worsening of health outcomes. And not even to say about women were adversely affected, I would argue probably more so than men. We might have this notion, some people have the notion that, well, enslaved women were given easier tasks. That's inaccurate. Women who were pregnant worked up until their pregnancy on farms and plantations, and there was no maternity leave. There was no prenatal care. There was no neonatal care. So this all goes into the story that we have now. Once slavery ends, we go to Jim Crow segregation, where African Americans aren't given access, going back to previous points, aren't given access to quality health care. Some African Americans in certain locations were able to establish private hospitals through various means, churches, missionary associations, and so forth and so on. But in terms of the general quality of healthcare, African Americans had little access to that, let alone once we get into the late 19th century and really throughout the 20th century, we have the high incidence of lynching that is happening, where white folk are extrajudicially killing African Americans, both men and women. So that's part of the mix. So, but getting back to some of this other things that we've already talked about in terms of housing and neighborhoods, again, when we look at what's happening, let's say from the right before the First World War, where this is the first wave of the Great Migration of African Americans leaving most of the rural South and going to places like New York City, and especially Harlem, or going to Chicago and settling on the South side of Chicago, or going to Cleveland and settling on the east side of Cleveland, or Detroit, settling on what was then the Black Bottoms. Those neighborhoods were all segregated. And it wasn't just segregated because Black folk moved to these areas and that's it, well, this is where we want to live. No, there was also a practice called redlining and restrictive covenants, where real estate brokers, all white, would literally on a map draw red lines on the city map and said, African Americans will live only in these areas. And if an African American of means, let's say, wanted to leave that area and say, I want to move somewhere else, well, there would be collusion in these white neighborhoods that would say, no, the house is already sold, or the price is raised up to prevent African Americans from moving into more affluent areas. So this affects health because you're in segregated neighborhoods, and as time went on, these segregated neighborhoods are underserved, both health as well as educationally, and this perpetuated into what we have now. We're also talking about other variables like income. This current president likes to herald that under his administration, African American unemployment has never been as low. And in one aspect, he's right about that. He was right in terms of before this, but the numbers, he's not really getting into the nuance of the numbers. Yes, the unemployment rate was down to among African Americans nationally 4.9% at the beginning of 2018. But you look at the income gap, the average African American family pre-tax was only earning like $48,000, almost $49,000. The average was $70,000. That's the average. So jobs, but what kind of jobs? So as we're learning, African Americans are disproportionately part of what now is called essential workers, frontline jobs, working as cashiers in grocery stores, where the grocery stores never shut down, or bus drivers, public transportation never shut down during COVID, working in healthcare, at nursing homes and in hospitals. Those things never shut down. So that then coupled with something else historical that's also bridging the gap between a historical study and historical methodology and medicine is the fact of all of the impacts of generational trauma and just current trauma that African Americans face just for being Black in this country, having to deal with the police, having to deal with real, in most cases, a lot of cases, tough living situations that gives rise to hypertension, heart disease, living in homes with asbestos or bad drinking water, as we saw in Flint, Michigan, but in other places in the country, leading to Legionnaire's disease. And I think the environmental racism is something that we have to really take account of in terms of understanding why we see the disproportionate numbers here. So I think that's all I wanted to cover for the time being. So I'll stand down. So thank y'all.
Wow. Thank you once again, Prof. Washington. It is so mind-boggling what you've just shared right now, from the history of slavery right down to what things are like today. It doesn't seem like there's much that has changed from what you've shared. I mean, it looks like people are still enslaved, but as we would say in South Africa, it's like slavery that went to private school. You know, it feels like that. And if that is the experience, it's such a terrible thing, because we look at things like right now, what the president of the US is saying versus what is actually happening on the ground. We believe what we see and read in the news, but when you tell us the actual experience of being Black in the US, it feels very different from the things that we read about. So you're bringing forward something that maybe we should think of as some of the factors that lead to the impact, why the impact is so much greater in the Black population. Because right now, what you are saying to us is all these things that we probably believe are nice and well and good about being Black in the US are not true. And that there isn't much that has changed over the 200 odd years. So thank you so much for that insight. And again, I'm going to plead with you to stay with us, because there's going to be a Q&A session where we are going to need you to, to answer some questions from some of our viewers and people that are interested in hearing probably more about what you've shared today. Thank you so, so much. And now we're going to move to the next panelist, Dr. Monwabisi, as Doc calls you, Dr. Munwai Ganjo. Just to share a little bit about him, Dr. Ganjo is a qualified medical doctor. He's a partner at Africa Rising Capital and an MD for compliance and strategy there. He was a registrar for medical schemes and chief executive of the council. And he was a founder and HOD of the South African Medical Association. He has worked both in the private sector and in the public sector in terms of healthcare in the Eastern Cape. He has held various international lecturing positions in US universities around issues of global health, focusing on health economics, health reforms, policy regulations or policy formulations, private health insurance regulatory frameworks. He also serves as a member of the Board of Visitors for the School of Health Sciences and Nursing at the Robert Morris University in Pittsburgh in the US, where he is a Rooney International Scholar. He has been since 2017. Dr. Ganjo has a strong corporate track record and has successfully managed large mid and downstream operations in South Africa. Now, he has a broad international experience and track record of leading and enabling transformation with an emphasis on regulation and operations, change management, and strategic planning. Dr. Ganjo, I think it is safe to say we're in the right hands, because you're in the forefront of this as somebody that's in healthcare, directly impacted in healthcare, but you're also in a very privileged position because you are able to be part of dialogues that could lead to change in how healthcare is delivered to our people on either side of the Atlantic. So you are in a very good position as somebody that could maybe give us insights in terms of some of the discussions that you have had with our counterparts on the other side of the Atlantic, where you also talk about issues of race and healthcare access. So maybe you could also, take a bit from that and share with us. And possibly from this, you will also be able to then assist us with understanding the social context and why the challenges that we have here in Africa and in South Africa in particular around issues of COVID-19. But what we are realizing now is that COVID-19 doesn't exist in isolation. There's been other healthcare challenges before, but maybe COVID-19 has helped to lift the veil and make us see how bad the impact has been to people of color. And over and above that, help us in giving us the understanding and the comparative discussion of how it is here versus how it is on the other side of the Atlantic. So hoping that from the commentary that you will give us, we'll be able to learn much, much more from somebody that's in the forefront of this. Thank you so much, and over to you, Dr. Ganjo.
Thank you very much, Pelogazi, and thanks, Dr. Fundile, for giving me and my colleagues this opportunity. Indeed, we are at crossroads, having traveled a long way to where we are. Firstly, maybe for the purposes of today's discussion, my experience both in South Africa and US, universities, faculties in education and health sciences on global health, and its many facets, specifically in the field of economics of healthcare, health systems, health reforms, and policy formulations, as you have mentioned, and many other historical and current initiatives. They seem to intersect and cross-cutting across the Atlantic Ocean, as we have mentioned, culminating in what is before us today. Including obviously the responses that ordinarily in a non-racial society, and I normally like to replace that term non-racial society by an anti-racist society. Probably that is a more explanatory and descriptive term. We should really not be finding ourselves having to justify our existence by resorting once again to call for being taken seriously as human beings who happen to be people of color, black, brown, etc. Well, I guess that has now led to formation of very powerful movements like the Black Lives Matter, Civil Rights Movement, United Democratic Front in South Africa, formation of the Truth and Reconciliation that we had in this country. And in the process, we unnecessarily lost lives, Pelugas. We have lost George Floyd. We have lost Rayshard Brooks in US. We did, in this country, lost Steve Biko, Chris Hani, and many, many others. And all of these people died in the hands of racist injustice, if one wants to put it that way, as we find the same kind of experiences in the diaspora and all over the world. We have had that in the previous discussions as well. We've had, and I'm going to work this out and relate it to the healthcare and the challenges that we're currently having. Secondly, the transatlantic roundtable discussion, I've been lucky over the past 2 years to participate in some of those discussions. And they've got biannual conferences that deal precisely with the areas that we're currently dealing with. And that has exposed many of us, myself included, in a uniquely position that introduces, and it tends to introduce what is called new approaches on global stage. As researchers and religious leaders and physicians and as mothers and daughters that we are, as fathers and sons that we are and have been, we in Africa and in the diaspora should be dedicating a lot of time on transformation on matters that talk to race relations and redressing the past injustices of the past for the good of all humankind. That vision, we should never be tired of doing it. You mentioning that you asked me to talk about, participate in this discussion on the transatlantic, when they call it a roundtable, very necessary initiatives, which only in July last year, which is 2019, in one college here in Kenya called Hekima College, there was a big discussion that took place that I had to participate in at its initial stages. And guess what was its theme? It was old divisions and the new social formations in Africa and in the diaspora. I mean, this was as if we knew at the time that the COVID-19 was on the horizon in Wuhan, in China. I'm talking about July 2019, and we didn't have a single case reported of the COVID virus in South Africa at that time. We only had it on the 5th of March. And they had it in China, and hence the name COVID-19, the 19 numerically, and that name refers to the year 2019. Now, key to the pertinent discussions that take place in roundtables of transatlantic nature, South Africa, Africa as a continent, and the US get involved in, they are very much well formulated, and they would relate to things like patriarchy, which you find in our society, which needs to be addressed. They relate to sexism, which is the flip side of racism, actually, when you look at it. The role of culture in the continent and in the diaspora. Now, in South Africa, the pandemics, all of them, keep on exposing very certain basic ignored fundamentals. That we in South Africa, you might be aware that we're looking at this national health insurance, universal access to healthcare implementation as a project, utilizing the data that many of our researchers have, and we should continue having these for the purposes of both costing and delivery of the primary healthcare and other curative healthcare services. Is helpful in understanding all of those. You'll always find when you've got a difficulty, if you go back to the basics, sometimes that's where it should be your starting point. And when it comes to many of the pandemics that we have had in recent times, and COVID being one of them, basic hygiene has been emphasized. Wash your hands, wear your mask, so that the whole question of trace, track, and treat people when it comes to this virus becomes easy to be done when people understand that these are the issues. When it comes to, because once you do those testing, you're going to end up with people that need to be investigated, as we call them, people under investigation, so that mode of transport, mode of treatment rather, will be worked out. And I'm mentioning these because it's easy for us to talk about isolation and quarantine. We probably never ask ourselves in those quarantines and areas of isolation, what are the conditions? What are the home-like conditions? What are the housing, transport conditions? How do you socially distance when you are in a cab or in a taxi? And that is the only form of transport you have. So those are the areas that I want to bring to the fore, because they do link up to the socio-economic construct of our society. And why am I mentioning all of these as experiences? And I think my duty has really been made quite easy by the introduction by Fundile and by Prof. Washington as to why are those all these, where did it all begin? And when did it all begin? We've got some answers today, confirming, in fact, some of the things that we've always suspected are true. We find people of color, Black, brown society that we are living in all over the African continent and in diaspora, in different continents, including African Americans, Latinos, Asians, facing same challenges of inequality, of access to quality and affordable healthcare. And this now is taking place in the wake of COVID-19 and HIV and AIDS, and now violent racism, as we have found in the US. Is it not shocking? In South Africa, as it is the case with many other countries, the right to access to healthcare is a constitutional imperative. And I'm sure other countries will claim the same, but I will talk for South Africa in this case. It is a constitutional imperative that access to healthcare. However, there are significant historical landmarks worth mentioning, during which these rights are thrown out of the window on racial grounds. And when they are subsequently restored, unfortunately, they are not guaranteed. They don't come with guarantees. And we have to deal with that aspect. History is littered with, both in the US and in Southern Africa, and in South Africa in particular, with this. You would start easily by 1652, an arrival of the first colonialists in this country, and then you can track it right up to 1913, the Land Act that we're battling with now, when people were emasculated of their own means of economic means. 1948 comes up with what we call apartheid, grand apartheid, institutionalized racism. You get to 1961, this country of ours becomes a republic, meaning independence, whatever that would have meant at that time. And 1990 comes up, becomes an iconic year. Nelson Mandela gets released from prison, precisely has been fighting for all of these injustices to be corrected together with his comrades. We go into vote in 1994 for the first time, and come 2020, what happens in 2020 in South Africa? What happens in US in 2020? You get Rayshard Brooks getting murdered by a policeman in the races. You get George Floyd, and I'm sure my colleagues from US, and I've interacted with many of them in US, then they trace their history of institutionalized racism and oppression. You recall there is something called the 1619 Project. First colonialists arrived in Virginia, and I spent some time in Virginia. I was lucky enough to be associated with a few of their universities there, Hampden-Sydney College, not far from Richmond, Longwood University in the same city. And I have heard and I've seen, I've met both my colleagues, African Americans, and together with people from the diaspora, reeling from the injustices of the past, having difficulty because they were asked to lift themselves by the bootstraps of their shoes. How do you do that if you do not have boots at all? We hear they would mention the very important years that took place, and Prof. Washington will agree with me. You get that from 1619 and come 1863, emancipation of slaves, and you are left without any means of economic survival. Martin Luther King puts it very beautifully, even under tragic conditions, how that happened. And then come 2020, we are, I do not have to repeat what we're seeing in 2020 with regards to this kind of as I conclude in this, I want to mention that when it comes to the healthcare and the economics of it, the political economics of it, rather to put it correctly, is that it's the national health insurance, private health medical aid schemes in South Africa, ACA, as it was mentioned by Amanda Mkaya from EPAI and from US now, and I hear that you grew up there. We love you for that. We think that it is an unsustainable model that we have, and it is becoming exposed even more by this pandemic that we have. HIV did its best to show it, which looks like we didn't listen. COVID comes up, it's giving us a rude awakening that it would appear to deal with this. It needs a global collaboration and a global effort. We've got a situation in this country where we've got modest growth on one hand of people going into the private healthcare sector because they think that that is where most and better care can be found, and only to find that you are turned at the door because you cannot afford what you're being promised. We have to do things very differently, and maybe one of the ways to do so is actually to change the whole system. People are very good in saying to change a system, you must be patient, you must take time. When you take time and become patient and you cool down, you might find yourself so cool and cold, like you're in a deep freezer of a fridge, because you take so long to change things. And yet the COVID did not warn anybody. It came up like a flash from the sky. And we have to do what we have, to a point where we're probably forgetting about a whole host of other conditions, chronic diseases that have been there before the COVID virus. All the resources are being now diverted to this for good reasons, but other diseases are not stopping in terms of the epidemiological spread and how they should be dealt with. I think that talks to, maybe that's, I'll leave the rest of the discussion to the Q&A, and then we can take it from there. I thank you.
Thank you so much, Putmonwai. Thank you so much for those insights. It is quite important for us to get somebody of your experience and exposure, because some of the things that you're bringing forth now are things that we probably wouldn't have known about. We guess that these things are happening. However, when you come with the facts, the way that you are, and you are somebody that is right in the middle of healthcare discussions and talks, with the intention to advance how things should be done, we then have to really, appreciate what you've shared. And I guess you're saying that in the Q&A session, some of the things you'll talk about them there, but maybe even before we get there, it would be interesting for you to tell us why Black males in particular seem to be impacted more by the COVID-19 than the females. I mean, it's interesting that a lot of times, most of the conditions would affect more females than males. But in this particular condition, we're finding that the statistics are saying more Black males are affected than any other. So it would be interesting to hear from you what the possible reasons would be for that. But thank you so much. We'll then keep you there until that time where people are going to be asking questions, and maybe you're going to give us more insights as we continue with the program. Thank you so much, Dr. Ganjo. And now we're going to move to our next panelist. I don't see him here. Oh, there he is. Damon Baptiste. He is a New Orleans native. He is one of the people that are friends of South Africa, in the sense that he formed an organization called New Orleans South Africa Connection for the purpose of cultural exchange between South Africa and New Orleans. And he started this company 22 years ago, and he is involved in community-based programs that are targeting young people with the intention of ensuring that there's behavior change, targeting health initiatives and teen health initiatives. Damon, maybe what we will ask for from you to shed a bit of light on is the issue of how the general healthcare challenges for African Americans and the possible impact of this on the psyche of the African American population, should be spoken about. We would like to understand how all of this is impacting on the psyche of people that are already experiencing a history of oppression and a history of being put at the back of the queue whenever there are things that are going to advance society. So over to you, Mr. Baptiste, and welcome.
Yes, thank you for this platform. Thank you to Dr. Dr. Fundili? Mm-hmm. Yes, Dr. Fundi and the people of South Africa. I've been a friend of South Africa for many, many years, and it's really very similar to things that are happening in the U.S. And now things are becoming exposed because of the COVID-19, and then also the second phase of the civil rights movement with Black Lives Matter. And in our city of New Orleans, it's coming out with the disparities of healthcare with people with hypertension, high blood pressure, and a lot of health ailments that are causing, the death rate to had increased at a time because of their poor healthcare, and sometimes of economics leading to not any healthcare until there's an emergency. So if you look at the studies and doing different writing grants and data, it's very, very alarming. It was a pandemic before COVID-19. COVID-19 is just really exposing some of the things that were not taken care of, which is really economic disparities. And it really boils down to a social justice, a social injustice movement. I'm actually in Memphis, Tennessee right now with a conference addressing how we're going to create a solution as to addressing urban Black communities and starting a pilot. And I see very similar similarities in the South African communities as I see in the urban communities of the United States. And if you look at our work over the history of the 22 years, we've not only talked about it, but we've actually been, very actively engaged in many different sectors with politics, education, music industries, and just, healthcare, exposure in the media areas. So it's warming to get on a Zoom call with some of these great professors with their expertise and knowledge and speaking the facts. So I think that's what this is really all about. So when people have a question, they could actually come to people that really want to help and give them the right information. I can't hear you.
Can you hear me now?
Yes, I can hear you now.
Okay, thank you so much, Damon. Again, we're gonna request you to stay until the end of the webinar, because there's gonna be a Q&A section whereby people can then ask questions, and you can answer whatever that you deem would be directed at you. But maybe from your experience in Louisiana specifically, or rather in the South of the US, where, well, from the stuff that we've read, you find that most of the underprivileged people are in that area more than any other in the US. Maybe you could maybe also give a bit of insight around that, and how the psyche of the people has been affected by those, those kinds of oppressions.
Well, I think what I gather, what you're talking about, the psyche of the people, it's really a behavior health, a mental health issue. When you're seeing things constantly on television about pandemics, and then when you're losing your job, when you're seeing your loved ones pass, and there's almost come to an area where there's no hope, in a sense, and it becomes a hopeless society. So we're trying our best to bring some people together that can dwell on some of the solutions of how the state of the Black community globally, but the state of Black America, and then the state of how do we connect with the African continent, to showcase a different type of mindset. Because if you're only looking at an impoverished mindset and you're not seeing yourself in a very positive, light, then sometimes you could almost be overwhelmed, and that can cause high blood pressure. That could, cause many other things: anger, anxiety, frustrations. And we're seeing a lot of these things play out, especially with, protesting and the police brutality that you're seeing on TV every day. It becomes, almost like a live reality show that just doesn't end.
Wow. Well, thank you, Damon. We will hear from you during the Q&A section. And thank you for the insights that you've given us. Now, we're going to move on to, well, we have a surprise guest, the Honorable Minister Senzo Mchunu of the Department of Public Service and Administration in South Africa. We're going to request him to come forward. Please unmute yourself, sir. Right. Welcome, Siyabonga, that you could join us. Thank you so much for coming through. Maybe for a start, if you can just tell us a bit more about maybe the historical background. We've heard from Prof. Washington about the historical background of the African Americans. However, now we are in South Africa, a country that is seen to be predominantly Black. However, when you look at the disparities that we're talking about here, they are still here in existence. Maybe if you could, for a start with a historical perspective of the poor circumstances of our people in this country, and take us as somebody that is part of the people that could bring solutions, because you're in Parliament, you're a minister. And what our expectation would be is that you could come with solutions because of the position that you're in. So maybe if you could help us with that and maybe get us to understand why the circumstances that we are in existence and what the government possibly is doing about it. So welcome to you, Minister Mchunu, and thank you.
Thank you very much, Pelogazi. And I want to greet fellow panelists on the side of the Atlantic and over it. And it's a pleasure to have all of you this evening. Now, firstly, our background in South Africa and to a large extent in the continent of Africa is full of colonialism, posed to us or on us by foreigners from other countries and other continents. And briefly, just to say that I wanted to look at colonialism in two ways. One, term it some kind of discount when you look at what Dr. Monaviso was saying, making reference to the Constitution, because the Constitution is there to be honored by implementing what it says we must implement. And so if we fall short, yes, we can look back and say the past constitutes some kind of discount because of this and that and that. But on the other hand, we shouldn't always seek discount. We should just stand up for what we are supposed to do at the time at which we're supposed to do it, and then move on. But let me look at, therefore, colonialism firstly. Well, colonialism by nature, it sought to differentiate and it sought to suppress, it sought to discriminate, it sought to put privilege where there was color, white color to be specific, and it was a greedy period of, it was greedy or characterized by greediness on those who were imposing it. Greedy for land, greedy for food, greedy for everything that you can imagine that their eyes could see, and so on. And it therefore is no surprise that in the process there would be victims and there would be victors. And in this sense, indigenous people in South Africa became, and of course also in the continent, became victims, and they got deprived, and among other things, any healthcare provision whatsoever. And by the way, clean water, education, and all those social issues that go hand in hand with being human. And there was no constitution, there was no legislative framework, there was no healthcare brought anywhere as an issue as far as Black people are concerned. All there was by colonialists, and the question of healthcare never arose in any case. If there was anything, it was all in traditional medicine, without necessarily any institution. And African people had their own way of understanding health and providing health, which is far different from what is happening now. But you can easily say that period was by and large characterized by absence of any worry whatsoever about providing any healthcare system, especially modern care health system, providing it for African people. And gaps when in a situation where you were doing it for white people, and therefore gaps started there and began to show. Over time, any health institution like hospitals and clinics, these are things that got associated with missionaries, with the church, and it went hand in hand with education institutions like schools. They're all over in the country, and that's when we began to see institutions like schools being provided for African indigenous people, and clinics and hospitals, so to speak, and trained nurses and health workers like doctors and so on. Now, so this was a kind of a wave in terms of getting African people closer to any healthcare system or any healthcare provision, so to speak about, which was over and above the indigenous ways of health provision. Now, apartheid came, and when apartheid was destructive by nature, and it aimed at everything about black people, wanting to destroy them from, I mean, in any aspect. Where they had a god, you wanted to destroy their god. Where they had rivers, they had water, clean water, you destroy that. Where they had means of livelihood in their own way, provided by nature, and with them helping themselves in whatever way. All of that got under attack and destruction because what the white men wanted was just your labor, finish and learn, and overnight they throw you into a camp, whatever name they called it, and they want you fresh in the morning, and you work for them until you are finished off for the day. And so there was but I mean during even that period of destruction, there was some kind of provision, not in any systematic way, just sporadic and just minimal in terms of healthcare institutions like clinics and hospitals, and some semblance of healthcare, but no dedicated system in the sense of a health system funded and provided for with transport and professionals and all of that. If you came across it, that's why even today, when you sit in a restaurant in South Africa and there's a doctor, a medical doctor close to that, half of you in that restaurant are likely to show each other that there's a doctor here. Because
sorry, Honorable Minister, we're battling to hear you. I don't know, there's something with your line that's making you a bit inaudible. So
all right. I don't know what it would be because I do see that I appear to be normal this side.
Okay. Maybe for now.
Yes, maybe let me try.
We're battling to hear you. We can see you, but we're battling to hear you. So okay. Perhaps if it gets bad, I'll let you know so that you can maybe switch off the camera, and then so we can able to hear you. Yeah.
Okay. Let me try and see how I can fix it. Thank you.
All right. Okay, you can continue, sir. Thank you. Like Minister Mchunu, we don't know what's going on. It looks like you've left your camera there.
Hello.
Okay. Yes.
Yeah, I think if Minister can just switch off the camera, then the voice will be better because it's a bandwidth issue.
All right.
It's a bandwidth issue.
I think
Okay. How am I now, fellows?
You're sounding
Fellows,
much better. You're sounding much better. Yes, yes.
I'm so sorry. I've switched off the camera.
Yeah.
It's fine. We'll pick you up later.
Yeah.
Okay. No problem.
Okay. Thank you. Thank you. You can proceed then, Minister.
All right. I was then saying during the apartheid era, there was some semblance. You can't call it improvement. You can't call it systematic because it didn't target, it was not provided in relation to numbers and geographical spread and so on. So you can't talk about any system of any kind. But then came 1994. And for the first time in South Africa, you had a situation where you had the constitution from 1996. And the constitution of the Republic, section 27, and I liked it when Monobisi made reference to it. He then started indicating responsibilities of government in relation to health provision. Section 27 talking about healthcare provision, talking about food, and talking about clean water, and talking about all those things as being a responsibility of government to provide, and on the other hand, talking about them as rights, rights of all the citizens in the country. And those were interesting times indeed. And that's where I want to say, then we have to agree that this was at the same time a challenge because it sought to break from the past where government had a free ride in terms of what they provide and what they don't provide. And now these things were prescribed in the constitution of the land. And there was then legislative framework accompanying that constitutional provision and seeking to give direction to ministers and to governments. What then has gone wrong? Because from 1996, it is that we've had a constitution, and the constitution is very clear in terms of the responsibilities of government, whether national, provincial, or local. I would say the first problem, maybe in passing, South Africa can't have enough money all at the same time to deliver this kind of service. Even though year after year, one of the biggest budgets every year in the country at any level of government, national and provincial, it is health. It always comes up tops with the biggest budget every year. But despite this, there's still quite a lot. On one hand, it points to the kind of gap and the kind of destruction and pointing government far way back in terms of closing the gap that was left or that has never been filled up by the colonial period and the apartheid period. And so even this 25 years of democracy isn't long enough and hasn't provided enough budget for government to pay the deficit and catch up with the period. And at the same time, you have had the population increasing. Now, in order to make this point much more clearer, you will find that white communities, in terms of their geographical location, these are provided almost adequately. Now, we're in one country, we're 25 years into democracy. It is because they crossed from the pre-democratic era to the new democratic era with these provisions in place. And nobody after 1994 destroyed such infrastructure and the system that was meant for white people, as though they were the only citizens in the country. The same applies to clean water, the same applies to good schools, and so on, electricity. So those things have been expropriated in over time to white people and white communities and white locations, as opposed to, that is when, as opposed to black-dominated areas. And that's where discrimination comes in a very stark way. So that although government has had a responsibility in terms of the Constitution from 1994, but it found that it had a lot to catch up with regard to black communities who are in majority, both urban and rural, and not very much to do except maintenance as far as white areas are concerned and white people are concerned. Come with private sector health provision, and private sector provision comes with a lot of expenses, which become a discriminatory in a way in terms of affordability for the large population, because it comes in the form of what must you have? You must have a card, you must have money, and take these systems that come with private healthcare provision. Now, that's the second issue that comes into play. But putting those aside, let me count the third one, that healthcare is not just healthcare provision in isolation from the environment, from other provisions for people. You need clean water, you need food, you need schools, you need roads, you need transport, and all of those provide you with a healthy environment. You even need health workers, adequate health workers, day in and day out, at night. Now, all of these things constitute a strong base for healthcare provision. It also enables you as an individual to face your own personal health with relative ease than when all of these things don't exist. And most Black people are exposed to a very disabling environment. You have to go for a long way, you have to walk for a long way. There's no transport to a clinic, to a hospital, and so on and so on. And much of those are concentrated in urban areas and so on. So all of those constitute lines that give rise to an inequality as we see it. And when COVID came, it finds us in this particular situation where health provision historically and up to now, because of various reasons, can't be provided at the same level of quality and quantity to all the citizens of the country. And it finds that the people who are sort of left behind and left vulnerable are the majority, who are the Black people. And as the figures that come with Dr. Fundile, this side of the continent are not a surprise. Perhaps one thing could be surprised is that this seems to get closer to men than to women, and where men are known to be stronger than women, but it's different with COVID. But notwithstanding that, these are the lines that are coming with what we see now in terms of high percentage of people who are admitted and people who are victims of COVID-19. But let me go back as I leave to the challenges. One other factor in terms of us lagging behind in terms of meeting our challenges in terms of the constitution is it relates to government performance. And in this instance, let me just take health. We don't have a system in South Africa where when you are appointed Minister of Health, you find in the office that there is a 10-year plan. So you get appointed and you then know immediately, first day you come to office, that there is a plan for 10 years, such that if you serve for 3 years, if you serve for 5 years, if you serve for 7 years, it's no matter. But you will have done what was supposed to be done for those 7 years. What most of the time obtains is that you get appointed, you are in a way provided broadly with what you have to do in terms of policies, in terms of priorities in some instances, in terms of budget, staff, and so on. But it is not streamlined in terms of naming it as a kind of a list that, for instance, says, as an example, if you are appointed as Minister of Transport, nobody tells you how many bridges you are going to build and where exactly you must build those bridges for the next 5 years. So that if you move out of that portfolio, your successor knows exactly that in your tenure or in the years that you were serving, out of 10 bridges that you were supposed to build in a particular province, you managed only 3 or 4. And the fellow knows exactly that he has to start from number 5 upwards. So there is some guidance, but in a country like South Africa, where you are seeking it as a developmental state, as a capable state, and with the kind of backlogs that we have, and with the inequality, I think we need to do more as a solution in terms of being specific and in terms of focus. I like what people did in Shanghai when they built Shanghai. They developed for themselves a plan to develop Shanghai into one of the cities of the world in 20 years. So it didn't matter which mayor, what time. It didn't matter what committee of whatever. What counted was that there was a plan, and you get appointed. You deal with it. You implement the plan, whether you were intelligent or not, whether you were a hard worker or not. There was something fixed that you needed to do, and you had to do it as put. I think perhaps as a solution, we have to learn and become much more concrete in what we want done in health, so that at national, at provincial, and at local, so that irregardless of who comes in there, they know that this is year 7, and there should be so many hospitals in which province, and there should be so many clinics in which province, and they know other priorities in name with regard to health provision. In that way, you are not leaving anyone to their devices and to their quality of performance. And I think somehow we can get closer to bridging the gap and fulfilling our responsibilities in terms of the Constitution. I will leave it at that, Pelowaz, and thank you very much for this privilege.
Thank you so much, Honorable Minister. And it is so eye-opening to hear some of the inputs that you've given there. However, I think it's also important for you to understand that you have everything in your hands, or as the communities of South Africa, we believe that our government has got everything in their hands, because now we voted our government into power, and I'm guessing that the people would then say, at what point as the people do we hold our government accountable? Also understanding that there's the various ministries there. Maybe it's time to look at a different way of saying these ministries should work hand in hand, especially towards combating a pandemic of this nature, where housing and water and sanitation, education, and maybe even communication that would take information to the people on the ground, and the various infrastructures that you spoke about, transport and all of that. Maybe it's time to find a way of getting them to work hand in hand, and possibly also having partnerships with the private sector, so that some of the weight can be, they can help our government to carry those. But thank you so much, and please don't go away, because we're gonna open the platform now to people to send their questions through, and we're gonna allow some of them to come through and ask questions. And maybe at this point, I'm gonna allow Dr. Nyati to just give us a little bit, after hearing all of the panelists speaking, maybe give us a bit of a comprehensive summary before we allow the questions to come through. Over to you, Doc.
Okay. Hi, thank you, Pelo. Actually, I am the host, but I think we should give more time, to the rest of the panelists. So I'm declining the offer to talk. Let's allow the rest of the panelists to actually, take questions and expand on some of the issues that they could not expand on earlier on.
Okay, maybe at this point we will ask for the audience, or rather people that have logged on, to just send through their questions. You can text your questions through, and then we will allow you to ask the question directly. That have logged on. Okay.
All right.
Got Lindile Maklina that has raised his hand. Can we promote him, please? To ask the question directly.
Yeah.
Okay.
All right.
Lindile Maklina that has raised his hand. Can we promote him, please?
Good evening. Am I on, program director?
Yes, we can hear you, sir.
Okay, thank you very much for the opportunity. I'm sorry, I must apologize. I was a little bit late. I was held up in another meeting. However, I heard very much when Dr. Washington was giving his input, and I was so taken aback by what is happening in the international arena vis-a-vis what is happening here at home.
Yes.
Now, the big question that is sticking in my mind, and as I said earlier on, I was a little bit later, so I didn't know, I don't understand the initial input maybe by Dr. Nyati. But the big question is, what next? Now that we've got this profound discussion held in this platform, which in my view and my understanding, it is of high level. Is this going to cascade down to the people in the ground, to the masses who suffer the brunt, especially when it comes to these social illnesses? That's one. Number two, I heard Dr. Mkhunu talking to the issues that the government, which Dr. Monwai also alluded to, that seeks to say it was in the constitution and it is in the constitution of our country to address issues like, and prioritize for that matter, issues like your health, your education, your water and sanitation, all these things. We are in now, he said himself, 25 years down the line of our democracy. What is it that can be done better, rather than us having him here in this forum to speak and say the government is trying? 25 years in my mind, or little mind, should have been a big chance that we made some inroads, especially in the rural areas where there is no infrastructure at all, where the people have to travel miles before they get to those health centers. And I think I must hold there for now, because I'm gonna miss my points here. Thank you.
Let's give this opportunity. Dr. Nyati, he wanted to know, after hearing what Professor Washington was talking about, and the various panelists spoke about around the issues of the healthcare, he would like to know if these discussions, which he thinks are high level, are going to cascade down to a level of solutions in this country.
Yeah. Okay. Thank you, Pelo, and thank you for the question. Yes, obviously, you know, because of COVID and the fact that there's still a lockdown in South Africa, yes, it's been relaxed a little bit. You know, it's not so easy for one to get to the ground in terms of face-to-face, you know, with communities. So what we're doing in the meantime is to leverage technology and see how we can use technology to get, you know, to the people. So, but one of the mediums that is very good to get to, especially people in the peri-urban and the rural areas of South Africa, is the use of radio. And you've got national radios, you've got regional radios, and also you've got what we call community radio stations. So at this moment, you know, as a grouping of healthcare professionals that are actually working very closely, you know, with the chairperson of the Solidarity Fund, we are exploring ways and means of taking these kind of discussions to community radio level. And we've already started in a place like Mthatha. Yesterday, we were passing on the messages, you know, around COVID with the UNITRA community radio station. A few days before in Mthanzane there's a radio station there at, I've just forgotten the name. And on Monday, we'll be doing the same at Nelson Mandela Bay. So the point here is that there are limitations because of, you know, the current environment, but we are looking at how to get the information to the people, because what we are hearing is that people on the ground, they don't have information, or at least they don't have adequate information, and there isn't enough public health messaging, but also getting information from the ground as to how best things could be done. Last week, we actually hosted civil society leaders who also have then committed to working closely with provincial health departments. As we know, health issues are actually the competency of provincial health departments and not the national health department. And so civil society organizations together with groupings of healthcare professionals like myself, we are trying to get messages down to the ground so that our people can be better informed. Hopefully they can, modify their attitudes and behavior towards issues of healthcare. And so I think that's the answer I can give for now. But once there's more freedom to move, other structures in communities like traditional, leadership structures, we will also work with them. So I think that's the answer I can give for now.
Okay. Just maybe to without diluting what Dr. Nyati has said, Putlungile, this is Dr. Nyati has taken this initiative to get as many people as possible to participate in ensuring that we do, you know, reach our communities and help out in our communities as a volunteer initiative. So the second question that Putlungile had was to Minister Mchunu, where he was asking that what is it that can be done better since we are now sitting 25 years after our democracy and that we do have a constitution as something that is going to guide us. So maybe Minister Mchunu, if you can respond to that. Thank you. Please unmute yourself, sir. Minister Mchunu, if you can please come through and respond to Mr. Makrina.
Sorry, yes. No, I heard him very well. Yes, the Constitution does oblige us as government at all levels to take these matters and our responsibilities seriously, as you were saying. But the difference between the way we're doing things during COVID and before is very distinct. Every week, Cabinet nationally come together and the Minister of Health give us reports. And what is clear about these reports, it comes in numbers. Who fell ill, who is admitted, who is quarantined, who passed on. It also covers villages. Which village seems to be under siege on COVID, which I think is something that can be done even on TV. On TB, it can be done on diabetes. It can, in other words, we can produce a map of every month, at least for the whole country in terms of the burden, geographically and in terms of numbers. And follow that with specific and tailor-made response and updated all the time. Now, there's a difference, therefore, in the way in which we are working now. We're dealing with it almost day to day. It comes with numbers. It comes with healthcare providers. We even saw all of a sudden that we're short of more than 200 doctors. And then we asked for Cuba to assist us. Now, if you look at COVID, the way then we respond now and the way we responded before, it's like we're not aware of these shortages in terms of medical doctors, nurses. We're even recruiting retired nurses. We even are able to tell you it's Kailicha in the Western Cape where we have a problem, which I don't think even in the Department of Health itself, they were able to deal with in the way they are dealing with. Now, to answer him, therefore, I don't think that after COVID, we're going to go back to the kind of laxity that has been there before. Even if it's not in a literal sense, but compared to what is happening now, even mobilization throughout the country, districts and provincial governments, it's health, health, and health. Of course, there are other responsibilities, there are other fields, there are other aspects of life. But at the moment, remember, it comes with water, it comes with mobilizing people in terms of the need for them to be conscious about cleanliness generally. And it comes with sanitation. It comes with quite a number of issues, even food for that matter. So if really COVID is anything to go by in terms of its positive aspect, we would not want to go back to a situation after COVID. After COVID, we need to take from where we shall have left off and move straight up to facing our responsibilities, more or less in the way we are doing we leave health in where they are, and they mustn't go back. We go for education. Education also do what they are doing now, and all other departments. And I don't envy the president, because he is going to have to really crack the whip as if there is more COVID. Then South Africa can turn around and be something of a better country, which will be even shorter than the 25 years that it has taken us to get to this consciousness where we are about our responsibilities and providing for the people of South Africa. Even shorter than 25 years.
Okay, thank you so much, Minister. Putlungile, I hope you answered.
Yes, thank you very much, ma'am. I forgot to actually thank Dr. Nyati for the initiative. Yes, we need leaders like yourself, Doc, who take the bull by its horn and spearhead and speak for the voiceless. Thank you.
Thank you, Puti. Okay, I saw two hands and then they disappeared. So there's two people that raised their hand and who wanted to ask questions. If they can please just raise their hands again so we can see them. I saw two hands and then they disappeared. So there's two people that raised their hands and who wanted to ask. Dr. Ganjo, just raise their hands again.
Yes, thank you. Thank you, Perogazi. You gave me a bit of a homework earlier on with one question regarding the male dominance with regards to acquiring this condition. That was one. The second one is in part answering the question on the social aspects and social, and I pin it to the social determinants of health. I guess this is a new virus. It's a novel virus by its nature. Our bodies as humans are naive to it, given the fact that these origins and zootic and coming in from animals and bats and so on. That being the prominent explanation. And I will not go to the conspiracy theories about it. As to what happens in the laboratory and that matter, I won't go into it, but it's one must not ignore it at the same time.
Yeah.
So why I'm saying that it's a novel is saying very little is known in other aspects. I do know that the academic institutions and many other technologically based institutions and laboratories are trying to find a way why men and not women. I don't know how important that distinction is, given the fact that remember we are the very first people to say we should be non-sexist, and in our, so let's not try to become sexist in a way when we're dealing with this matter with a virus here that we should be preventing, and we should be dealing with it. Breast cancer does affect men as well. 1% of men do get breast cancer.
Okay.
Now, having mentioned that, the issues, a number of papers have been written, both in US and in South Africa, trying to understand the very causes of it, what it happens to the human body, what in medical terms we call the pathophysiology at a microgranular level. And those studies would be taken from postmortems and on one hand, and they would be taken from people who have recovered out of it. South Africa, and I think globally, the recovery rate of people suffering from the COVID is fortunately above 50% of cases do recover. And that is why it's important to have this area, or rather this period of quarantine and letting people self-isolated for 14 days and monitor them closely. We did talk about when they are being monitored in self-isolation or in isolation, it depends. You and me might be having a spare bedroom in our house and it's easy to self-isolate, but what about somebody who comes from New Brighton or Khayelitsha or in Harlem or in Watts township in California, where this luxury of self-isolation does not come as easily as it happens with other communities. And again, there comes in race issues here, because socioeconomic people affected by those who would be racialized and coming from a specific race, again, Black, brown, people of color are affected with that. That is just one point that I wanted to deal with it. The postmortems that came in from Milan in Italy, and the ones that we have probably starting to look at this kind from those people who have died from this, will give us a better and an arrangement. And lastly, just on that point, people who have suffered from this terrible, terrible, terrible flu, that so many people have died from it, and those who have survived out of it with now what is called convalescent plasma. Their blood has been exposed and their blood has got antibodies that should be examined to deal with that. Enough for that highly technical information. Here is the issue though. Social determinants of healthcare. Minister Mkono has touched on it quite extensively in many different ways. Social determinants of healthcare keep on coming up because it is not about the antibiotic and an injection and the hospital and the ventilator that will help us out of this. It is that environment in which people find ourselves. It is that mask that is covering the mouth and the nose, and not hanging just under the sleeve as I see people wearing a mask. It should be covering and be worn properly, because the environment is an important part when it comes to this. You must remember that the study was done in 2007, and it's a seminal study, in my opinion, where it indicates that 30% of the disease difficulties we have worldwide can be traced down to genetics. Your genes have predetermined your fate when it comes to that. That's only 30%. But 60% of the problems we are having come from behavioral things that we do, environment in which we find ourselves. And then the 10% is on the healthcare systems, health policies, how well the whole institution is the whole health system and the policies are working. So I would say that at the basic level and this early stages to really cut and prevent what we see as a scourge and as a double whammy that we're having both in developed countries and undeveloped countries, HIV and AIDS and COVID. So that's a double whammy. HIV and AIDS and COVID and violent racism and other in the diaspora, that's a double whammy. And we should really be, it's not necessary for us to be facing racial injustices that lead to people being killed. It's distracting from the important aspect which will prevent difficulties that we have in people contracting these diseases and many other diseases. Lastly, Chair, you know, the new normal should have started a long time ago, but then here we are now. People need to know that throughout the history of humankind, new things happen and change people doing things in different ways. Here is one opportunity. It is not good that when you have got large numbers of people that are not socially distancing, that are not washing and sanitizing their hands, that keep on touching their noses and eyes and faces when they don't know where those hands and fingers have been in the presence of a COVID virus that we have. We have to not be gathering in the form of many funerals that we are having and attending and spending enormous amounts of money. 50 people, it's a new normal. People must know that from now onwards, we're going to have to behave very differently than we've been doing before. Those are being the basic issues that we should be concentrating and educating our people on, and stop these distractors that are coming in up and killing people on the basis of race.
Okay. All right. Hello.
Thank you so much, Doc. Dr. Nyati, let me hand over to you.
No. It's just there's a question that was asked about why males seem to be having more, prevalence of COVID-19 than females. Well, up until recently, it was thought that it may be something related to lifestyle issues, the rate of smoking or the immune differences. But some of the recent literature is actually pointing to the fact that male hormones, or what we call androgens, are actually a predictor of COVID-19 risk. And they've even given it a name after the first doctor in the US who died of COVID-19, Dr. Frank Gabrin. So people like me who are bold-headed, there is getting to be a lot of research that actually says the levels of androgens or male hormones are so high that they also aid the virus to do its job much more efficiently amongst males. So, but there's not enough research at a larger scale. So, but the point I'm trying to make is that there is something about the levels of male hormones which make people like me to lose hair on top. I see Prof. Washington there as well. So he's got the Gabrin sign. So that's now becoming a sign that's a predictor of this. Let me just read it for you. Lead author of the key study behind the association, Prof. Carlos Wambia from Brown University, is quoted in the report as saying, "We really think that boldness is a perfect predictor of severity." So yeah, I'm sure more research is going to come to explain this, but for now, something to do with the levels of male hormones.
Thank you so much, Doc. Those hands disappeared. I don't know. I don't know who the individuals were, and they're not raising them again. So you are muted, Doc. We can't hear you.
All right, you can give the panelists, time to add other, inputs. Prof. Washington, Mona Davis, Damon. You can give us your inputs as we go towards wrapping up the discussion in the absence of questions and answers.
All right. I think we'll start right at the beginning with Prof. Amanda Otter. If you just come through, Prof, and maybe, throughout the discussion, there's probably certain things that you would like to add over and above what you shared before, because I'm sure with the discussions, there's certain thoughts that have come through. And if you could just share some of your thoughts with us. Thank you.
Actually, I have more of some questions more than, thoughts, but, okay. The whole session was very informative to me, and I've gained a lot of, information about, even South Africa, although I'm a South African, but you learn something new every day. Mm-hmm. So, but I have a question about, which is, I know that they say that the virus is very aggressive during the winter time. I don't know if there have been heavy studies on that. I just wanted to know that since South Africa is actually, I think, in the winter stage, what are the, the preparations and the strategies that have been put in place to kind of like avoid, the country reaching its heaviest and highest peak, during the COVID-19? And anybody can answer that question.
I think I'll direct that question to both Dr. Nyati and Dr. Monwai.
Let me come in on. Thanks for that, Amanda. And I don't know. You get quite a bit of conflicting information with regards the weather, whether it's winter and summer. Obviously, when it started in China, it was in the middle of their their winter there. And we had to gear ourselves for that, even in South Africa, which now some reports are coming up that maybe whether the coldness of the weather or the winter summer kind of a situation, whether it is as serious as it was initially mentioned. But I mean, look, anything that is not harmful, anything that can help would have to be considered and not be ignored. Just that we can't change the weather. We can't change the fact that it's winter now here. And the tragedy with that, if that that information is correct, is that the lockdowns that are taking place, we have got a lockdown that we're reducing it from level 5 to level 3 now in the middle of winter. The Dr. Fossey, is it Fossey in US? The gentleman, that's correct. He gives a very pointed counseling when he says, and he refers to the lockdowns that are being graded down, that when you've got your foot on holding on your accelerator and you are holding it there, it's not about the time to release that foot off the accelerator as it is now, especially this time of the year. But obviously, if he says that, he subscribes to the view that winter predisposes COVID virus to spread more than in summer. So that's a little I can contribute towards that question.
Thank you.
Thank you, Doc. Dr. Nyati, any input there?
One point,
Doc?
Yeah.
Yes, Minister Senzo?
Yes, Spanner in this is what one person was talking about Lesotho. Saying Lesotho is pitched very high, more than most countries in the continent, higher than most countries in the continent. And COVID-19 infection is very low. And I asked why, and he says no. Lesotho, there has been a long established practice of children being vaccinated by some vaccine, which is 3 in 1. We didn't get to name the vaccines. It started, as it says, during the time of Liabua Jonathan, they were doing it for something, and long after his death, the thing has been practiced in Lesotho. Now, how scientific that I really don't know, but it made me to sit a little straight to look at is it like that? But seemingly there are low figures there, and I don't know what actually scientifically accounts for that. But like Dr. Munobisi says, the weather thing, I've heard many experts saying we shouldn't attach too much importance on the weather because scientifically there's nothing concrete. But at the same time, the trend seems to follow that kind of thing. But the bottom line is distance, clean your hands, and all those matters. Is it well? I just wanted to make that point. It's all about us. From where I sit in the continent, there is a very good coordination that is emerging, which was not there before, via the chair of the AU, and we also on this program called APRM, which is chaired by South Africa at the moment. We are meeting quite often, and we receive reports from CDC just to check the trends, check what is happening, and so on, sharing ideas and so on. So there's going to be a lot of there's going to be a need for a lot of coordination, closer coordination continentally, and look at ways and means of amassing all the requirements to fight COVID in our box of the continent, as it were, and talk very often, so that whatever gets done, it gets done throughout the continent in order to contain this, including trying to raise funds led by the chair of the AU. The move is quite promising, that closer coordination, closer sharing of information, closer sharing of what works. Quite promising that closer coordination,
okay,
closer sharing of
Thank you.
closer sharing of what works.
Okay, thank you. And we have Nongeba. Thank you so much, Minister. We have Nongeba Mulwele.
Hello.
Yes.
Hello.
Yes.
Let me introduce properly. Nongeba Mulwele is the Speaker of the Council of the City of Joburg. So she is actually Madam Speaker, Nongeba Mulwele, you know. So Speaker, you have the floor.
Thank you very much. Thank you very much, Doc, and thank you very much, Spelogazi and the panelists. Unfortunately, I joined late. I had a series of meetings today, but I thought that, no, let me join. There is no way that I can miss this discussion, especially because it's a discussion about something that is close to my heart in terms of educating the citizens. So I caught the discussion right at the tail end, but mine, what is important is about, you know, information. Information is power. And because when I joined, you were talking about the prevalence of the disease, especially in men. And so I have learned something out of the discussions that I found in place. For me, as a public representative and as a person who is leading in a city which is an epicenter of the pandemic, it is important for me to get as much knowledge as I can so that I am able to transfer this knowledge to the citizens. The minister spoke about the importance of adhering to the regulations. And this is what we always tell our citizens. But unfortunately, it is not everybody everywhere, particularly in the townships and in other areas where we lead, where people do adhere. There are still people who think that the disease is still very far from them. And the more we talk about it, the more we have these platforms, and the more people think that the disease is still very far from them. And the more we talk about it, the more we have these platforms, and the more
Okay, I think we've lost the speaker there. So Pelo, you can take over. Yeah, I think give a chance to Mona Davis or to Prof. Washington.
Okay. We'll start with you, Dr. Mona Davis. If you can please come through. Again, I'm sure throughout the discussion, there's certain things that have come up in your mind, and if you could share those with us.
I've been sitting here listening to all of this interesting information and impactful information, and I want to get down into something that we have got to always have in the back of our minds, the we process. Because while we look at an overview of what disparities look like and how we handle disparities, we have got to concentrate, because this is a fast-moving virus that is taking over lives quickly. So while you're sharing the information with the people, you've got to have that next step in place of testing, tracing, and tracking. You've got to do that. If you don't do that, all of the information just will not help you. We're in a bad situation here where people were not listening, they were not traced, they were not tested, they were not tracking, and it's running rampant. And so now that, as the doctor spoke about the new normal that we're moving into, this is a new normal. It's not going to go back to what we were used to. So we have got to prepare ourselves now while we're in the midst of taking care of this, of how the new normal is going to look, and get folks acclimated to what their new lives are going to be. That means that jobs are going to change. That means that how you interact is going to change. That means that everything that you did previously, you may not have access to that ever again in that form or fashion. And so when we're having information sharing and we're talking about moving to a new healthy place, we've got to let people know that the things you used to do, let's relook at that. Doesn't mean that life is over or it's ever going to end. This is going to change. Another day is going to come, and we need to be prepared for that future movement. It's all weeds. It's all weeds. So that's the work that has to be done. And the bigger people. So we've got to get people in place, that transition of moving to the new normal. When jobs change, we've got to get people in place that are going to be doing these new positions and looking at this new technology and how we share this information.
Yeah.
To the new normal, when
All right.
jobs change, we've got
Hello.
people in place.
Yes. Yes, just before Prof. Washington, I just want to mention that the issue about testing, tracing, and tracking, you know, it's a very, very important issue that Mona is actually raising. It actually, it's one of the areas in our, response as a country where we have a challenge. We have a challenge because our capacity as a country to actually test and get, everyone tested is seriously restricted. We had already started pushing what we call community screening and testing. And out of that, the samples that came out, they actually choked our system of laboratory services, both in the private and largely the public sector, to an extent that we've had to now slow down on the, going out there. But the focus is now on people who are symptomatic, who are presenting to healthcare facilities, or people who are already in hospitals, or those who are considered high risk, because we just don't have enough. And what is the problem? The problem is that, countries like the US and other countries that produce some of these reagents that are required for the testing process, they are putting their countries first before they could export stuff to countries like in Africa. So we are having challenges as a country in getting the necessary cartridges that are part of the testing process. And we have not yet had approval of what we call rapid tests in this country, which would actually help a great deal. Our regulator for medical devices is busy testing those for accuracy and all of that. So we have a bottleneck because all tests must go through, the National Health Laboratory.
Mm-hmm.
So that is the challenge, and I hope that soon enough we'll be able to address that, because without aggressive, testing in the communities, we are now having to ration healthcare services because of the increased demand and the limited capacity, and prioritizing certain groups of people. And in the Western Cape, which has got about 60% of the load to date, they have now come up with a system whereby if you are under the age of 55 and you don't have any comorbidities, you know, then you may not even be tested as a way of trying to leave capacity for the more higher risk people.
And those folks that you're speaking of that may be under 55 without some of the pre-existing challenges, they have got to be on point in understanding how to care for themselves and making sure that anything that they experience or that they come into an environment with, that they have got to be able to regulate how they're wearing their masks, the gloves, washing their hands continuously, making sure that the things that they use are things that are appropriate for what we need to impact this diversity. Folks who are predestined, there's so many. I have, all of my friends have either one of the challenges, either they got hypertension or they have diabetes or they have asthma or they have heart disease, and so everybody's home, you know, but it's really difficult because it came on so quickly to be able to change your mindset, but we have got to be in the business of changing that mindset. Everybody's home, you know, but it's really difficult.
Thank you so much, Dr. Davis. If we could have Prof. Washington, Prof. Eric Washington, if you could please come through for any additional stuff that you'd like to share with us.
Okay, thank you. And thank you to all the panelists and all the good information that's been shared this afternoon, this evening over in South Africa. I was pleased to hear from Dr. Ganjo that he was at Hikima College in Nairobi last July. I was there too. I don't remember seeing you. I've been part of those discussions and part of those conferences with TRRR. So it's good to have someone else who's been part of those round tables. I just want to reaffirm one thing that we've been talking about, whether in the U.S. context and definitely in the South African context, is what we're seeing is the results of structural racism, institutional racism, historical racism, systemic racism, however you want to define it. These are the results. Racism is bad for your health if you are on the receiving end of the negative aspects of racism. This is abundantly clear to somebody like me who studies this throughout the diaspora. I heard a study not too long ago, actually it was 4 years ago, and at a transatlantic roundtable conference in Trinidad. David Williams over at Harvard, as well as the dean of the faculty of the law college at University of West Indies, St. Augustine. David Williams argues that the effects of racism has negative impact on health. But also what Professor Antoine at University of West Indies in Trinidad, she took part of a study. She was part of a study that was Pan-American, and that study revealed that in every country in the Americas where you have a substantial or visible population of African descendant people, they were at the bottom of socioeconomic measurables. So whether it didn't matter if you were in the United States, or you were in Brazil, or you were in Venezuela, or Colombia, or Honduras. If you're an African descendant person, your group represented the bottom in terms of socioeconomics. So it all stems back to slavery. That's the common denominator. So the legacy of slavery is very much with us. The past is not the past is present. And so with that said, as a historian, these systems, our societal systems, our societal structures in the Americas, but also in South Africa, reform is fine, but there needs to be really an eradication of these systems. because the systems were designed to oppress African bodies, Black bodies. So people say, well, the system doesn't work. Well, some of us are arguing, no, the system is working very well. And these are the results. The system kills. So that's why I'll end my closing remarks.
Thank you so much, Prof. Thank you so much. And yeah, I guess this is food for thought. And as we move forward in finding the solutions, yeah, I think we need to also bear in mind some of these things that you've shared with us. Thank you so much, Prof. And now I'm going to allow Damon. Damon, if you can please unmute yourself. Damon. Thank you so much, Prof. And now I'm going to allow Damon. Damon, if you can please unmute yourself. Damon, are you there? Can see you, but we're not hearing you. Damon, can you please unmute yourself? Damon, are you there? Can see you, but we're not hearing. Okay, whilst we're waiting for Damon, I will allow Usis Nonleba to please come back because she wasn't done yet. So Usis Nonleba, please come back. I will allow Usis Nonleba to please come back because she wasn't done yet.
Thank you very much, Sis Pelogazi. Thank you very much, Sis Pelogazi. And my apologies for. Thank you very much, Sis Pelogazi. Thank you very much, Sis Pelogazi. And my apologies for. Thank you very much, Sis Pelogazi. Thank you very much, Sis Pelogazi. Can you hear me?
I can hear you now, yes, Sissy.
All right, my speakers are letting me down. I don't know what the problem is. I was still appreciating. Can you hear me?
I can hear you now, yes.
Yeah, I was still appreciating the information I got here on board, and I was saying I joined these discussions that Dr. Nyati have been holding in different platforms because my interest really, especially about this pandemic, it's information that has to cascade down to our communities, because the more people are aware and the more people have information and the more people know that if you are tested positive, it is not a death sentence, but these are protocols that one has to follow, then the better for our country. Because for me, I'm being motivated by people who have survived. You know, even when I look at the stats, I look more on people who are survivors than those stats of people who have passed on. And that's how we should motivate our people to say, if you are tested positive, that's not a death sentence, but this is how you should behave. And also you should be an ambassador to inform other people on how to prevent. And if you are infected, how then to make sure that you become one of the survivors. So for me, really, I would really want to be on these platforms for information for our citizens. And as a leader in Johannesburg, for me, I think many people could follow these discussions on different platforms so that we are all empowered. I really appreciate this. I hope I had joined earlier on at the beginning of the discussions, but I hope to be joining earlier next time so that I can properly participate. Thank you very much, Sis Pelogazi. Thank you very much, Doc, for inviting me. And thank you to the panelists.
Thank you, Madam Speaker. We really appreciate your input and your participation here. It means a lot because we know that you're one of those people that are active, even on this platform. I've got a hand from Richard Yanki. Richard, if you can come through. One of those people that are active, even on this platform. I've got a hand from Richard Yanki. Richard, if you can come through. Record, you please.
Can you hear me now?
Yes, we can hear you now. Thank you and welcome.
Yes,
good evening.
Oh, thank you very much. I just smuggled myself into this session. I won't reveal who helped me smuggle myself. My name is Richard Janji. I'm from the Western Cape. I work, as you know, Western Cape in South Africa is the epicenter.
Yes.
But within the Western Cape as an epicenter, the metro of the Western Cape is, but I work in Khayelitsha, the biggest township with African people in the Western Cape. It is in terms of sub-district, it has the second biggest rate of infections in the province, with as of today, with currently about 5,500 infections. Because the amazing thing is that it has 81% recovery, which is important. There's just two things I want to share, because what we have done, we have assembled ourselves as members of parliament, councillors, NGOs, Community Development Forum, and set up a structure called a COVID team in Khayelitsha, where all parties participate. Because our approach was, we are dealing with a common enemy here that all of us must focus on and deal with. We'll deal with other issues after we defeat COVID.
Yeah.
And in that process, we have created and opened what we call 2 pages, basically. Page 1 is your current COVID situation, and the purpose is to save lives. We don't have a luxury of discussions. What we have is how we save lives, and that page 1. So, and therefore, page 2 is us simultaneously, and not waiting for the next day, simultaneously begin to address what we call underlying causes or conditions. And so if we call the premier or the mayor of the city was saying, this is what we want to do on page 1 in terms of all of the protocols that must be done. But in the context of Khayelitsha, the health indicators are indicating that you have so many people who are diabetic, you have so many hypertension and so on. But in terms of focusing just on saving lives on page 1, we had followed a kind of 4-pronged approach. I'm sure you would have spoken about it. And where we discovered where the failure is, and everybody agrees. So your first one is screening and testing. So in the context of the Western Cape and in Khayelitsha, we saw that happening. But number 2 and number 3, which is your contact tracing, quarantine and isolation, became a problem in the Western Cape. Because people who got tested were never traced, kind of your contact, and also not quarantined or isolated. In fact, people were refusing to be quarantined or even isolated. And this is what we're currently dealing with now. So where you have on daily basis an area like Khayelitsha having about 200 infections, new infections that are coming. And so yet the government had planned quarantine sites that are 30%, 20% full, because people do not want to go to those quarantine sites. What that does, it spreads the local transmissions. So that's the problem that you're having. The 4th leg, obviously, is your health facility, your care, your beds, and all of that. In the Western Cape, that is now becoming a problem because we're getting into full capacity in terms of those issues. I think the beauty with us is that we are beginning to see results in how you can mobilize the community, because we're able to draw in all the three spheres of government in one meeting, in one session. So you would have a deputy minister on Sunday, you had an executive mayor, the premier, everybody that matter in terms of this issue to be brought in. And so if the mayor says, as we met with him on Friday, we're bringing, because you've got malnutrition issues, you've got food hunger, and I mean hunger and all of those, we are going to bring food kitchens. Immediately we say food kitchens are not going to help into the future, we want food gardens. So you link the two things. It helps us to address what we could not address for a very long time. Hence my point about it's important to deal with the 2 pages at the same time. I mean, if you go to the US now, on the COVID thing, the US is still on page 1, it's not on page 2. The page 2 of in the US is only on the racism issue, which is your Black Lives Matter, in relation to how they want to deal with policing and all of that. That for me is an important issue. But I wanted to have a question on some of our US-based, before I end, US-based participants. I wanted to have a simple question that says, I mean, where are they getting all of this wrong? I understand the historical issues of inequalities and all of that. I hear that, I get it. I'm asking in relation to the failure of the US on page 1 in confronting and saving lives. Because when you compare that with Europe, there's a vast difference. The curve of the US is rising. New York took a bigger part of that. It is declining now, but you've got other states that are increasing the curve. Because from where I'm sitting, it looks like an issue of leadership, basically, at the top, but at various other levels. Because it's not just a Trump issue. It's a collaborative issue. Because in South Africa, as I'm saying, I'm in Khayelitsha, you've got a president and the Minister of Health who's very clear. But if those communities in the provinces, in those cities are not coming on board, there's no way that you're going to deal and attack this particular issue. So what we have seen is that COVID has created new opportunities. So there's a one bad side, difficult side about it, but it has opened new important doors that we don't want to let go. For example, you never had a situation in Khayelitsha where chronic, vulnerable people who are old age had their medicines drop at home. It happened because of COVID, because you want to protect them, not to go to clinics, and therefore you drop their medicines on daily basis or weekly basis, and would want those things to continue. Because part of the Western Cape biggest problem is that they are poor in primary care. They are good in the curative side. So the primary care is the weakest part that you have in the Western Cape. I don't know about other provinces, but from where I'm sitting, and I'm hoping that Gauteng and others are learning, because this wave is coming to the Eastern Cape, to Gauteng, and I hope by the time it is there, they would have learned a lot from the mess that we're in, that we're trying to make sense of. Thank you very much. And I hope by the time it is there, they would have.
Thank you, Put Richard, and I hope Sis Mangneba and Put Richard, you'd be able to compare some notes. But maybe if you could have somebody from the US,
Yeah.
Amanda. Yes.
Yeah. Can I just quickly link up something with Mr. Janji?
Yes.
Yeah. I think the input from Mr. Janji is quite valuable for South Africa, in the sense that, firstly, Mr. Janji is a member of parliament. You know, he didn't want to disclose here, but he's a member of parliament, a very important person. But I think what I like about him is that he is also on the ground in terms of what's happening in Cape Town. Now, the Western Cape is one of the 9 provinces of South Africa, but it's the one that has got more than half of the load of COVID-19 as we speak. And a lot of people, you know, they are leading in terms of the infections, they are leading in terms of the deaths. You know, the blacks in that part of the world are actually the ones who are getting the highest load of COVID-19. So the issues that he is talking about, I think a speaker from Johannesburg, you should arrange to talk to Mr. Janji to see how the city of Joburg can learn from some of the experiences and the things that they are doing on the ground in places like Khayelitsha, Nyanga, Guguletu, and places like those. So I just wanted to link up that information.
Certainly, yes. Thank you.
Right.
Does anybody know what is the cause for that?
For what? Amanda?
For the high numbers in the Western Cape.
All right. I think Mr. Janji will answer, but one of the reasons is the fact that the Western Cape and Cape Town specifically is the mecca of tourism in this country. All right. So it's the mecca of tourism. Most people who come from outside, international tourists, their #1 destination, you know,
Cape Town.
is Cape Town. So therefore, the load of new infections being imported into the country started there. As much as Gauteng appeared to have more infections, but when you look at infections per 100,000 population, you know, Cape Town has always led from the beginning. And so it's related to that. And unfortunately, it's a service type of business. And these people, they go back to social circumstances that are quite bad. So issues of social isolation and all of that, it's not easy. Quarantine, it's not easy, as you heard from Mr. Janji. So it starts from the tourism service business to the communities, and it spreads there. And the poor social circumstances, poverty, people would rather go and look for food than worry about the potential of being infected by a virus. So I think that's some of the things that Mr. Janji can actually add. This is just my theory.
Thank you, Doc.
Mr. Janji?
Yes, if can I come in to add to Dr. Nyati? And I think he is quite correct. In fact, you would, to understand it better, you've got to take New York, the epicenter of the US, because it has a similar kind of a pattern, like Cape Town being a tourist attraction, but also a highly densified kind of a state. That's what we have. That's part of the reason why New York had so many cases. At some point in New York, we had 800 people dying a day. Today, it's good news when about 50 or 100 are dying. That's where it's coming from. But in the Western Cape, in addition to what Dr. Nyati is saying, was the origin of that, the trigger was tourism. But once it was in the Western Cape, there were clusters, what we call clusters of the triggers. So your retail sector became the major cluster, your farming in the retail, because for the people of Khayelitsha, they imported that from where they work. They work all over in the Cape Town metro, as cashiers, as petrol attendant, as police, as this. So that's how they got it. So it became the cluster. So Western Cape was known as that. And once it gets into communities like Khayelitsha, where 80% of an area is informal settlements, it's like catching fire, basically. So the local transmissions, then it's easy because you one meet 5 people and then it just spreads like that. Unlike in areas where it is an established area, you've got a big space, you are in this house, but you don't know who else is in this house. You don't necessarily have that in terms of your Cape Flats and your informal kind of settlements. Hence the 90% of Dr. Nyati earlier on about who is suffering from this. The people who are infected, affected, and people who are dying. It is exactly that layer of our communities. It's your essential workers, those who even at level 5 were not at home. They had to go at work as drivers of buses, as health workers, as police, as cashiers, and so on. And once they brought it into a densified and concentrated community, it was always going to be difficult. To add fire to that, health indicators in 8 sub-districts, including Khayelitsha, pre-COVID, you always knew that it's a pity that we are now beginning to see people who are dying, but pre-COVID, people were dying because of those health indicators of TB incidences, HIV and AIDS, including malnutrition for that matter. So COVID got to be fed with those kind of vulnerabilities and as opposed to other areas. So that's what is causing the spread. Obviously, part of what we're dealing with, because we also don't want to romanticize this issue, that our communities have taken a long time in taking this serious. For them, it was like, no, it's not our thing. That's not our disease. It's happening. They did not social distance. The only time they will be at home, it's when it is raining. Otherwise, they just don't believe that. So you have to enforce those kind of things. And the people who came first, who stay in better places, when it comes to lockdown and staying at home, they do those kind of things without fail. So you've got this kind of mismatch. Basically, I'm saying the issue is not just the issue of the conditions where we stay. It also has to do with kind of a certain culture of discipline as well. If I were to take you back, just before democracy, we had what we call boycotts. There was a time, lockdown is not new to us. There were times when we introduced stayaways for 3-5 days. So that was a different type of lockdown then, but it did not take long. So lockdown is not new to those kind of communities because that has become part of the struggle that we're in. But I think let me pause there.
Thank you. Thank you so much.
All right. Hello. We need to work towards wrapping because we're supposed to be ending at 9 o'clock. So I don't want us to stretch this. I know we have not heard from everybody, but in terms of protocol, we will need to have the minister, giving his last, input. But Monet, if you also want to say something before the minister, you can say something. But the last person must be the minister, so that the government must have that opportunity.
No, thanks, thanks, Fund, and the Honorable Minister Mchunu. I really won't take much of your time. I think that it's a great opportunity with regards to the transatlantic perspectives of the pandemic that we are having. It is always useful to compare notes and find out how do other people experience and how do they deal with the challenges that talk to the access of healthcare, and in this case, the crisis that we are having. I think in conclusion, I can only say that the new normal should really be a continuation of a normal that should have taken for many, many years ago, centuries, 400 years ago. There should have been normality. There should have been normality that would have been carried up to now, and we now are starting going on forward because we are responding to a crisis and we've identified how best to deal with the basic issues of combating this coronavirus together with other epidemics. So with those views, and I would say, Funs, thanks so much for creating this platform. It is very useful, I can tell you. Thank you.
Last words from you, Mona.
I want to say thank you, first of all, for allowing me this moment to share some ideas with you. You all have got a wonderful opportunity to make things better and bigger. Out of all of chaos comes something good. So if we can mind our weeds and make sure that we're taking care of the least of these first, that will mandate how we go forward. And I thank you again for allowing me the opportunity to share with you.
Thank you very much. Prof. Washington, your last words before the minister wraps up.
Thank you again. This has been a great conversation that we've had, and again, I love the transatlantic conversation. And yes, I'll echo what Sister Davis just said, that in our communities, we do have to focus upon those who are most vulnerable. And in the United States, it has been apparent that those who are most vulnerable are people of color. So if this is an equity issue, which I think we agree that this is an equity issue, not an equality issue, then the resources must go and be directed toward those who are most vulnerable. And in the United States, it's definitely people of color.
Yes. All right. Amanda, Professor Amanda Otter, can you unmute? All right.
Hi, God.
Amanda,
Hi.
yeah, just before. This lady is in the US, and where she comes from in the Eastern Cape province, her metropolitan area has got the highest load of COVID-19 in the Eastern Cape province. So maybe you should work closely with us and see what can we do for PE. Otherwise, you may not have a place to go to when you come back.
Oh, that would be a shame. Well, thank you very much, Doc, for organizing this. And I've joined your other webinars, and you're doing a great job. And especially, you know, with this panel that you have put together, I'm very grateful to be part of it. In terms of Port Elizabeth, I'm actually working with 2 organizations there, where at the beginning of the pandemic, I was helping them to have access to, you know, the PPEs and also the mask. But that was at the beginning. And now it has just gone, you know, being out of control. But I'm still working on the grounds. And my mother, who has a small nonprofit organization, she actually feeds the homeless, you know, in Port Elizabeth. So, so this is actually, you know, such a tragic time in our lives, but I'm just really, really grateful that I am able to join the panel and have my input. And I look forward to, you know, more, you know, conversations, because the more we discuss and the more we come up and we share information, you know, the better citizens we become.
Okay, thank you very much, Ceci. I think now it's time for us to ask the minister to wrap it up for us. There is something that is called the National Health Insurance System that's coming in South Africa, which is meant to try and address issues of inequity. I thought the minister maybe can just touch on that, so that at least there's something that we can look forward to try and address some of these legacy issues from both colonialism and also apartheid.
Thank you very much. Just to extend greetings to the speaker of Johannesburg and my colleague in the National Assembly of South Africa. Back to, firstly, I really want to express my humble appreciations to the panelists, all of them, but to your wonderful ability to create a platform and attract people with wide experiences from the US and from South Africa and make them agree to spend 3 hours talking on this very important issue of contributing to the fight against COVID, but also look at some of the issues that are arising with it. And I agree with Professor Washington that we should really lay more emphasis on solidarity with those who are most vulnerable throughout the world, and do what we can to really come to their side and to their aid. As for us in South Africa, the NHI is a wonderful initiative, even endorsed by the World Health Organization, based on the principle of universal coverage of all the people, regardless of color, geographical area, age, and make them feel that they belong somewhere, regardless of the extent of their wealth and poverty. But that when they cough, when they suffer and require access to health facilities, the country would care. And that is what we're driving at the moment. And on principle, in terms of principle, that's a wonderful initiative and process that we're in. But we have to put more emphasis on how we will manage this. And when we appoint, please wake up, learn from the past, and ensure that everybody who works for this financial assistance or financial system to assist people will fulfill its objective and indeed assist our people financially. And perhaps one day it will also expand and become a system to pick up every other aspect or related aspect, just like the NHS elsewhere. But my last word goes to you, Dr. Nyati. You are a wonderful person, and I would think that don't tire, just work harder, and pull up. It's a wonderful platform to talk to people outside government platform, and you get fresher and getting such wonderful ideas. Thank you so much. It really was an honor to participate here. Thanks.
Thank you. Thank you, Minister. You know, here in Africa, to our friends on the other side of the Atlantic, we still have what we call clan names. You know, clan names, we actually put more value on clan names than we do our surnames. So the minister has got some clan names, you know, Matingwane, the other one is Ndabezita. You know, so if you want a favor from somebody, the best way to get that favor is to actually call them with their clan name, you know. And if you want people to work with you in a team situation, get to know their clan names, because when you mention that clan name, it touches something in their hearts. So thank you very much, Honorable Minister Ndabezita. You actually helped to give respectability to this from the government side. We've got a strong panel of people from across the Atlantic, but your presence was actually quite useful for you to sit for 3 hours just being part of this discussion. It's something that is not common for people at your level. So I want to thank you. And also to our speaker of the city of Joburg, Madame Noneba Mulwele, thank you very much. I know we're doing a lot of work together, in spreading the messages across the city of Joburg. We will continue to do that. And to Mr. Richard Kyanji, from the Parliament in Cape Town, keep on doing the good work and keep on holding, the executive of the various arms of government, responsible for delivery. I know you didn't want to share that kind of information here. And I know we also have got the Deputy Public Protector who chose not to ask any questions here. I hope that she will also continue to make sure that those who abuse the funds that are actually meant for the people under the name of COVID, they will be held to account. And so I want to thank everybody who joined us via the many social media channels. It's been a long, 3 hours, but we hope that you've picked up something from this discussion. It's not the last time we are discussing these matters, but going forward, we will continue to look at different angles because at the end of the day, the solutions to this problem are actually going to come from us, the citizens of this country. So thank you to everybody. In English, we say thank you. In Zulu, we say siyabonga. In Xhosa, Amanda, sithi siyabulela enkosi. All right. And I think for our friends from across the Atlantic, I'm not sure if there's another language beyond English that you guys understand. But in French, it's merci beaucoup. In Portuguese, it's obrigado or obrigada.
Spanish, gracias.
Yes,
Muchas
gracias in Spanish. Yes. So thank you very much. We have really had an enjoyable conversation. But I also want to thank Pelogazi. She's actually my younger sister. I actually forced her to be the program director here, and she did a good job.
She did a fantastic job.
Monway, I was exercising my big brother, powers, because when I was 11 months old, I had to be weaned from breastfeeding because she arrived. So I still have an issue with my father. Why did he, make a baby when I was 2 months old? But anyway, thank you very much, everybody who joined us. Thank you to the minister. Thank you to the speaker. Thank you to Mr. Chanji. Thank you to everybody.
Thank you, Doc.
Thank you, Doc. Thank
you.
Thank you.
Thank you very much. Keep up the good work. Keep up the good work.
Keep up the good work. Keep
I'm
spreading the word.
All right, thank you so much.
Enkosi.
Assalamu.
Enkosi.
Thank you.
Thank you.